Thanks everyone, and glad to be back again this week. So what I've done is I've taken one of our scenarios that we've delivered this one yesterday, so it's kind of fresh in my mind. Slightly it's about 90% of what we delivered. We made a few modifications yesterday to it, but so it's one that was freshest in my mind. So I've copied this into the template, and I'll kind of work my way through it. And if people have questions during it, maybe they can type them into the box, and John can ask me, or if they want to ask at the end, then fire away. But by all means, stop me along the way if you want. I'm kind of going to be looking at my screen. I might not see the questions, but if someone wants to ask a question, then just fire away, just stop me. So obviously, the first bit is all self-explanatory, the name of the team. And these were all the people that were involved in designing it. And the title of the scenario is Anaphylaxis in the ICU. And we'll just go down to the summary. So some of this is what we were talking about last week. So the scenario learning objectives, they're mapped from the clinical competency booklet of the postgraduate diploma in ICU nursing. Now, I know that your ones are going to be more team-based, and this scenario could be absolutely turned into a team-based scenario as well. And that could be done with a few modifications, really. But this is the scenario that we developed. And I said I would work with a real scenario that we developed and we run here rather than making one up completely. So this one has been mapped from that curriculum. And also on the next line here, you'll see that the learning objectives are mapped to competency. So the competency, they've kind of a clinical competency book as well as the course. So besides the actual academic stuff that's in the course, they have a kind of a core clinical skills competencies that they have to achieve when they're out in clinical practice as well. So learning objectives are also mapped to some of the clinical competencies of that as well. So I've kind of listed those as well. So and mapped them to this scenario. So you can see there's that identification and management of distributive shock, which is anaphylaxis in this case, respiratory and cardiovascular assessment, management of respiratory and cardiovascular compromise, and the use of vasopressors and inotropes. And also under there, I've put down what the scenario addresses as well. So we're looking at situational awareness in this scenario. And as we kind of walk through the scenario and talk about it a bit more, these things will be kind of become clear as well. Identify and responding to emergency, escalating care, teamwork, and communication, and so on. So then, gone too far. Apologies, it's getting a bit mad with my mouse. Sorry. Okay, so the scenario is based in a ICU side room, simulated one in our case, up here in ASSERT. But obviously, if someone's doing something like this, it can be done on the board, an ICU or wherever, and who it's aimed at. So this is kind of the overall, the overall aim or the overall goal of the scenario. It's upskilling junior ICU nurses. They're dealing with an infrequent but life-threatening emergency. So if we're kind of looking at that, and we're thinking about what we were talking about last week, it's shown that how it's mapped to a training curriculum, how it's mapped to clinical competencies. So we spoke about this briefly last week, and it kind of shows where where it came from. Its needs analysis as well. So so we've kind of identified that, and the people that are involved up there, and I have missed people, I'm sure, are people that we sent this out to. Some people were involved in designing it, some people were involved in reviewing it. And if I count 1, 2, 3, 4, 5, I've definitely missed people because we sent it out to some people quite a while ago. There should be about 7 people up there. And I think I'm probably missing 2 names. So apology if anyone's watching it and their name isn't there. There's probably 1 or 2 people I've missed off this. So then underneath, you've got a scenario synopsis as well. So it's pretty short, you know. It's a 65-year-old patient who's been in ICU for 3 days, had a Whipple's procedure for CA pancreas. And he's been doing well. He's actually better yesterday. He's waiting for discharge to the ward, and he develops anaphylaxis due to IV antibiotics. So it's pretty short, you know. It doesn't have to be a big, huge, long story. And that's all that I've put in there. So I think it tells you what the aim, overall goal of the scenario it is. It tells you what it's mapped to, the learning objectives and where they come from, and what, you know, what the scenario is about. You know, people will do this differently. I'm not saying this is, you know, it has to be done this way, or this is the absolutely best way of doing it, but this is the way that I've done it anyway. And the target audience, the junior nurses working in the ICU who are enrolled on the postgraduate ICU course. So down to the next bit. Learning objectives. Next bit. So quickly, accurately, and safely assess a deteriorating patient, and we tell them how we want to do it, which is the, you know, the go-to approach for a fast assessment of a deteriorating patient. A, B, C, D, E approach is what we want them to do. We want them to be able to identify that this is a very sick patient and call for help. So we have that in as the second one. And safely and effectively manage an anaphylactic patient. Follow the guidelines, and good resource management, crisis resource management, you know, communication, teamwork, those type of things, using all your resources, situational awareness, and planning ahead. And as we get to the last couple of pages, we'll be kind of teasing those out a little bit. The desired background, the protocols, have them all in here. They're all links that all work. And when we send these out to people, you know, and we gave these to everyone as pre-reading as well. And we kind of assumed that they read them. And in fairness, you know, when we ran this scenario, you know, everyone was fairly clued up. So, you know, we assumed and we're pretty sure that everyone had gone through it, and the other scenarios as well. So we're pleasantly surprised that everyone was kind of knew their stuff when they came. Obviously, we have to.
Can I ask, Dave?
Yep.
When you do that and you give people pre-work preparation, have you actually also told them in this scenario that it's going to be a case of anaphylaxis? I mean, you wouldn't take a genius to figure it out anyway when they read the preparatory. I mean, would you generally have weighed the odds in their favor in that way, or would you be inclined to sort of push people into the deep end, or does it vary depending on who the person is that's learning?
Okay, I think it's a good question, and I think it depends on the course, and it depends on what we're. It depends on the course, I think, and I think with this course, the simulation fits into a smaller part of a whole postgraduate diploma. So they're getting lots of stuff on shock, getting lots of stuff on lots of different things. So we ran scenarios on cardiogenic shock and that kind of stuff as well. But there was lots of information on other things that didn't come up in the simulation. So they didn't know for sure that they were getting an anaphylaxis scenario, if that makes sense. And oftentimes we run anaphylaxis, we don't tell people they're getting anaphylaxis either. And sometimes we don't preload people with all this stuff. But we could tell that people had really read through everything before they came. And no, we didn't tell them they were actually getting anaphylaxis at all. And it could have been one of lots of different things they could have got, to be fair. But they were given all the material beforehand, and it was quite a lot. I was a little worried we might have been giving them too much, to be honest with you, but they seemed to get through it. But they had months, you know, this was done over quite a long time, you know.
Yeah.
So, right. Where are we now? So obviously we've this in it. This is for us too, obviously making sure that we know it, you know, and we're referring to it as well. So where it's situated, simulated side room, you know, obviously you'd be picking all this out. And the roads. There's only actually one candidate in this scenario. I know that's a bit odd. Often people work in pairs, but nurses in the ICU sometimes, you know, they're working in a side room on their own. And we kind of developed this a little bit as well, that, you know, sometimes that they could be sent on transferring a patient where they're on their own as well, with a junior doctor. So that's why we kind of put them on their own in this one, which is slightly unusual for us. We often have, most of the time, have people working in pairs. So it's a little bit different than what we normally do. And the other two are confederates. So the nurse giving the handover and the junior ICU doctor. And we'll talk about their roles in a little minute. Sorry, I'm gone. My mouse is very sensitive. Sorry about that now. And then we have all our resources here. So I listed out everything I could kind of think of that we used for the scenario, all the syringe drivers, all the ECG leads, all that kind of stuff, non-invasive blood pressure, you know, and this stuff will be pretty obvious to whatever you're going to be doing anyway. Abdominal drains with fake blood in it, that kind of stuff, and, you know, urine catheters, all that kind of stuff, notes and ICU charts. Obviously, I know in most ICUs, certainly in the CUH, it's all electronic. We're not electronic here, but luckily I have some of the old ICU charts from before, and we just have to use those. You know, we just explain to people. It's only the newest of the new staff wouldn't have come across them, but they're certainly able to read them anyway. That's for sure. So we'll use those. We load up X-rays, and if we're using something like head scans or anything like that, we'll load them up onto the PC for them. And any algorithms, obviously, we'll make them available as well. So people will use EMED a lot here, like they do in the hospital. But you know, if it's something a little bit more unusual, then we'll either print it off or we'll load it up on the computer for people as well. A very important thing in ICU is this one will be the emergency drugs and the bedside equipment. I'm not sure, some of you may have worked in ICU, but every bed space should have its own emergency drugs and bedside equipment. And the forms one of the checks when you take over from the patient. And it's actually one of the steps that we're looking for later on as we break down the scenario as well. So we have to make sure that stuff is actually at the bed space as well. Otherwise, we're kind of setting them up to fail a little bit. So as we kind of step through the scenario, what I've done is the baseline of the patient is what I've called the first stage. So the patient is sitting up in bed, feeling well. And I kind of said it's first kind of 5 minutes, and that's just left the people, you know, to settle into the scenario, get their handover from the first person. So you've a nurse handing over, and that nurse becomes available later on if they need a hand as well. So if they call for help later on, then that nurse will come back. But they hand over at the start, and they need to get a detailed handover from that nurse and assess their patient, and then to check, like I was saying, to check the bed space and check their equipment to make sure that they have everything. So that will be emergency drugs, and it'll be all their you know, BMVs, their bag and mask, and what we call a water bag as well. So a different type of bag that runs off the oxygen, that's got a PEEP valve on the side. They'll need all this kind of stuff. And if your patient had a tracheostomy, they'd have to make sure they've got a trachea the same size and one smaller. And if your patient's intubated, they'll have to have all kinds of stuff beside the bed. So they need to check all this, and their suction's working and all this kind of stuff before they start, or before they actually take care or take over care of another patient. They should be checking all this, and all their infusions are, you know, they've got enough drugs left for at least a couple of hours before they take over. So this all the stuff they should be doing. So it's a kind of important thing that they should do before they kind of accept that they're going to take care of the patient before the other nurse leaves. So we'll be looking at that, and that's why we've got communication in there and teamwork. So these are the kind of things that, you know, we're going to be looking at. So the cues there is, you know, the nurse handing over. We'll just mention the antibiotics. They're not going to make a big deal about it, but it'll just form part of the handover. And nursing handover in ITU should be very detailed. I mean, they should go through the body system and every body system bit by bit and cover everything. So it should be discussed, and the other nurse should pick up on it. And the IV antibiotics have just started, so the patient should be okay, you know, till, you know, they'll just be dripping away and slowly. By the time the nurse leaves, then and is left, then the anaphylaxis will start. And the patient has kind of got the script there, which links back to the script, which is on the next page. You know, the patient's just chatting and friendly, and you know, there's not much going on there really. So we're just letting them settle in, get their hand over, get their bearings. Like I was saying last week, that, you know, you want them to settle in and get comfortable before anything really starts, and get their bearings. So you can see all the initial settings on the monitor are all fairly normal. So there shouldn't be too alarmed at the start. So then once the nurse leaves, our anaphylaxis will start, and it's kind of 3 minutes down, from 5 minutes to 8 minutes. The patient starts feeling very unwell, complaining of nausea, headache, feeling sick, and our cues there are, you know, patient complaining of those things, but also saying that they feel that, you know, something's very, very wrong with them, and they should be alerting the nurse that, you know, something is very, very wrong, you know. So we want them to do a ABCD approach, and you have to excuse me, dyslexia and dyspraxia kind of ruling in there. I think there's an extra B or D or something in there. I can't see properly, but there's definitely an extra letter that shouldn't be in there. So we'll take that out. There's probably a couple of typos, so excuse me if there's see some A, B, C, D, E. Yeah, approach. Okay, if you see some typos. Okay, so that's what we want them to do. And if you look down, the learning objectives are linked to learning outcomes. So they will link back to those numbers up here. Actually, I think I've got them underneath as well. So sorry, be easier to come down here. So the numbers there, these ones on the side, will link down to whatever these ones are. So I copied them below as well. So. I have to stop using this mouse now. Okay, so then our patient worsens, and it's 5 minutes. So this is a bit longer. So we're just really giving. First, we got the second. Sorry, the second stage is 3 minutes, and that's really just assess their patient. Again, but you know, a quick, fast, you know, approach to assessing the deteriorating patient, and to check all their vital signs again, and to monitor it. So that's only 3 minutes, but then as the anaphylaxis moves on, it's they've got a bit longer. It's a 5 minute stage there, and they should, at this point, where, you know, they should identify that this is a crisis situation, and they should be calling for help and applying, you know, high flow oxygen or a rebreathe back. And you know, we don't write 100% oxygen, because non-rebreathe bag doesn't deliver 100% oxygen, so we tend not to write that in ICU. It's only if someone's intubated to get 100% oxygen. So that's what we'll put there. So high flow oxygen or a non-rebreathe bag, something like that. And you know, we kind of hope at this stage maybe they've identified the cause. They might not have got around to that yet, but you know, they should definitely know that their patient is extremely sick. There's something really not right going on here. This has been a big change from this 130 on 80, you know, this heart rate of 80 to blood pressure just starting to tank to 90 on 50 to 110. And the respiratory rate now, you know, is gone up to 30 and from 16, and they're wheezing a lot, and their stats are dropped to 90. They should be very concerned, and they should really be starting to think, you know, that this patient might have anaphylaxis. And the patient's complaining as well. The cues here, you know, are, you know, becoming difficult breathing, and becoming very anxious as well. And they're starting to give the prompts if they're not picking up on what's going on, you know, angioedema, tongue swelling. So we'll move that on to this stage as well. So we'll keep giving the cues and the prompts. I've just written in here just to remind, you know, whoever is doing the patient's voice, you know, to just keep giving the cues and the prompts as necessary to guide them towards anaphylaxis. There's no tricks, you know, like we don't do any tricks or try to catch anyone out. So, you know, we want people to do well. And, you know, they're not going to get the visual cues that, you know, you'd get in real life as well. So, you know, you have to help them, you know. You know, you might put some makeup on the patient's chest or something like that, to make a rash, and you could pull down the chest and, and show them if you want to go that far. But, might not necessarily be necessary if you start telling them that you've got a swollen tongue and they're itchy everywhere. And just keep giving those cues, they'll soon get it, that it's, they should soon get it, that it's anaphylaxis. So next stage then, we're on to the full shock state. At this stage, they should have certainly picked up, we would have hoped that they would have picked up that it's anaphylaxis, and they should have identified what the cause is and stopped it, and give the IM adrenaline as well at that stage. Your patient now is, decreasing level of consciousness, and got severe stridor as well, and their blood pressure 75/40, and they're more tachycardic as well. So I think this is just move on to the next page as well. So if we just look underneath, respiratory rate's 40, and their stats are 85. And we give the adrenaline, and we've kind of said how much adrenaline we want them to give, which is 0.5 milligram every 5 minutes. And we'd hope that they'd give them about 2 liters of crystalloid as well. So, liberal enough, they'd squeeze in the first bag and they'd start hanging up the second bag, and they'd be put it in a rapid infuser under pressure, that they'd start squeezing that in fairly fast. And they'd ensure that when they call for help, that the help has arrived. And when they do, they're given a fairly quick but fairly clear and concise handover as well. And we don't want them messing around with second line treatment until the first line treatment is sorted out. So we want them given adrenaline every 5 minutes and the fluids, and sorting out the patient is often, hydrocortisone going in first, and often Piriton going in first, and not enough attention to the adrenaline and stuff. So we want to make sure that the patient's getting the adrenaline, and their blood pressure has been sorted out with the fluids as well. So you can see there's more learning objectives here, and they all starting to link down to what's below as well. So and our prompts there are: junior doctor will not take the lead, but will be helpful. And this is because we're trying to upskill. If you remember at the very start, the aim is to upskill the junior nurses. So we don't really want to spoon feed them that much with it, in case they get stuck in a situation where they might find that they have to deal with this, and it's an emergency you have to deal with fairly fast. So that's why we want them to get the adrenaline in fast, and at least give 2 adrenalines, and at least squeeze in 1 bag of fluid and start getting the second one in fairly fast. So what we've said here is that the junior doctor will turn up. They haven't dealt with anything like this before. That'll be helpful, but they'll be a bit unsure of what to do, and when we kind of run the scenario, we have them kind of flicking through trying to find the algorithm. They're not entirely sure what to do, and they say, look, we should get someone else to help. So the other person to help is the senior nurse that handed over in the first place, because the doctors, and I think the story we give is the senior doctors are busy with a patient that's self-extubated around the corner, and it's like an ARDS patient, and they're really busy at the moment. There's no way they can come down, and they'll be down in like 5 or 10 minutes when it's sorted. So the senior nurse will guide and prompt as needed, but we're trying to push participant to lead as much as possible. So that's what we're trying to do. So the things then we thought that might happen, and trying to keep the scenario on course. So the patient will get better when, I was trying to highlight the green bit. The patient will improve when they get 2 adrenalines, IM, and the fluid resuscitated. And they've had at least 1 liter in the second bag is at least hanging. And, when we get to that stage, then we'll move down to the improvement part. And that's only 2 minutes, because that's more or less the winding down of the scenario. If they only get 1 adrenaline, and they start moving on then to giving the hydrocortisone and the Piriton and not giving the fluid, the patient stays in the state above, which is pretty sick. So that's what we want. That's why we're trying to get that message across, that they need to stay on top of giving the adrenaline and the fluid and resuscitating the patient properly. Now, because it's junior nurses, they probably won't give IV adrenaline. We don't really want them doing that, but you just never know, because there could be someone on the course that's very experienced and dealt with this before, that they might give 1 IM adrenaline and then they might restart an adrenaline infusion that's up there already, or they might just turn on an adrenaline infusion and bolus it through the syringe driver, and they might give 50 mics, which they could do, or they might just restart an infusion of adrenaline and give 50 mics and start doing it that way. And that is in the algorithm for people that know what they're doing. But it's not the message we're trying to get across to them. But if they did it, there wouldn't actually be anything wrong with it as such. But you could make a mistake if they drew up the wrong amount. They drew it up in the syringe and they give the wrong amount. What we've said there is if they give more than 50 mics IV, then the patient will get runs of bigeminy. If they give 500 mics, which would be, given a whole lot IV, which we see happen in simulation sometimes, the patient, there's a good chance they'd probably arrest, but we don't really want to do that. In this, we'll talk about it afterwards. So we just give them a sustained tachyarrhythmia, and we'll talk about it afterwards. The dangers of kind of doing that. So that's kind of the if the person does A, B, C, D, or E, that's kind of thinking out of what might happen. Now, no one gave any IV. They all gave it IM. So, we didn't have to go down that route. But, these things can happen. And people who've dealt with it in ICU might handle the situation slightly different. And if they've actually dealt with it in real life, then in the past, and more than once, they might deal with it slightly different. So you just have to think of all these things. So then obviously your patient improves when they've done these things and your blood pressure comes up a little bit. But your patient isn't 100%. So they'll need to start thinking about the next steps, and that's, probably starting an adrenaline infusion, noradrenaline infusions. And your patient's going to start needing probably their lines back in. So, the ART line's already out. So setting up for lines. They already have a central line, but you're going to need to start monitoring that again. And those kind of things, so they're the kind of things then that we would expect them to do, really. So the debriefing part, I've put learned objectives back in there as well. So they're fresh in everyone's mind of what we were trying to achieve in the whole thing. And underneath where the learned objectives met, because they may or may not be, or not all of them might be met. Do they follow the algorithm? And if not, why not? And, the importance of, we could, in the discussion, the importance of following the SOP, which is the algorithm. So, the algorithm for anaphylaxis is the SOP for it. So, and then we could, things that could be discussed would be the difference between the implications of stepping outside of the algorithm and deviating from it, or deliberately not following it, which are different things. So, like I was saying, that someone might decide that they might restart an adrenaline infusion instead, which, if someone has an ART line and CVP lines and stuff like that in ICU, might be more appropriate than just giving loads of adrenaline, because they're totally monitored and that kind of thing. So all those things could come up in discussion afterwards as well. But, the things we'd be looking at then would be, discussing the importance of the first line treatment as well, about staying on top of the adrenaline and the fluid resuscitation. And all these things then, they all kind of go back to the resources as well. So, this would be for people that might be debriefing as well. So they can obviously they can check the resources beforehand in case they get asked the difficult questions, that they know where that information is as well. Okay. And then just talking about anaphylaxis as well in general, and the common myths and facts and controversies about treatment and all that kind of stuff, and there's resources for that kind of stuff as well. So this all can be decided between the people designing the scenario on what can be discussed, and then looking at the teamwork and the group situation and awareness and that kind of thing as well, where the resource is used and discussing. We're talking about resources, obviously that includes people, and planning ahead is a really big one as well. And how they're going to plan for the next steps for the patient. Often we'll see when we're dealing with anaphylaxis scenarios that give the adrenaline and the patient gets better. And, you know, a lot of the time they do, but, you know, in ICU, you know, they might think, you know, that's where patients end up when they don't get better. So these guys need to think about, if your patient isn't going to get better, what are you going to do? Because that's where they end up, you know. So that's why we have the next steps, and that's setting up like your vasopressors and your NORAD. But then it's like taking, you know, often they won't respond to those, so they'll have to start thinking about drawing up hydrocortisone infusions and vasopressin infusions and things like that. Other therapies like putting patients on hemofilters and things like that, and possibly giving things like methylene blue and all those kind of advanced therapies that they have to do for anaphylaxis patients if they do end up in ICU, because they have refractory anaphylaxis that isn't getting better. So they're the kind of things that we were discussing with them. But obviously this, you know, would all be decided between you know, the group of people that are putting the scenario together. The evaluation, I think you're doing something on that next week. So, you know, I just actually just put in a line there just for myself. But, you know, evaluation could be between, you know, could be some kind of post-scenario questionnaire. And you get these simulation competency rubrics. And you can get these off the internet for, you know, fairly easy. There's lots of resources out there for simulation effectiveness tools. There's lots of resources around. I think Healthy Simulation actually have a couple of these that you can download. They've links to ones, and they're all from reputable places, like from universities and from you know, healthcare centers in the US and the UK and places like that. So you can check them out. But I think that I think it's next week. I think you have something on evaluation anyway, so I left that bit out. And the actor scripts, I think I put the participant in the wrong way around. Sorry. Sorry, it's been a very busy week. So I was actually just for the final touches on this about 50 minutes beforehand. So you'll have to excuse me. All right. Okay. I think this is supposed to come at the end. Okay. So your participant script anyway. And there isn't much that we gave the person coming in. Just you're working in the side room. You've been asked to go in and take over the care of a patient. And 3 days post Whipples, they're waiting to go to the bed. They're still waiting for a bed in the surgical ward. That's probably all you'd get before you go in and get your real handover. The doctor's script. It just gives a synopsis of the patient. We do this every time. I'll show you actually the scenarios, how we put them together ourselves as well. I just want to show you the last page of how we put our ones together. It might be useful if you want to stick it at the end of this, and I'll show you why in a second. But I won't go through the whole thing because it would just be repeating itself really. But the last page I think might be useful for you. It's just, yeah, the synopsis again, and it's just telling you, you know, you're new to the ICU, you've never seen anaphylaxis before. Or dealt with a lot of emergencies. You're helpful, but you're not comfortable taking the lead. We kind of discussed that earlier. And then just saying that all the senior staff are busy with an emergency. And the ICU nurse is a bit longer, really. It's just the person giving the handover. They're experienced. They give a detailed handover. Like we're saying, the focus is on actually managing the anaphylaxis, and we're setting them up the best way we can. So to do that, so we're giving them a really good handover. We're doing all that kind of stuff, so they can just focus on managing the case as best they can. And you know, we've kind of pointed out that they have antibiotics, so they should be thinking of this kind of stuff. We're not making a huge deal out of getting antibiotics, but they should be able to kind of know, you know, that they've heard it in the handover, so they should be fairly clued up that that's what's going to happen. Not what's going to happen, but when it does happen, that's what it is. And I think that's just a list of Confederate information. So what's this one? See detailed copy your scenario design. All right, this is consumables and equipment and that kind of stuff. So, you know, just like, you know, where the dressing is going to be, you know, that kind of stuff. So it's, you know, that kind of thing as well. And your abdo drain and stuff, volumetric pumps, what you need, all that kind of stuff. So that's the way I read it anyway. loading X-rays up onto the PC, that kind of stuff. I think I kind of mentioned that earlier as well.
Yeah, I guess, Dave, I mean, the intention with this section of the document was, I would imagine that in most of these areas, the Confederate would have the full information sheet. This is just to highlight logistics for them, you know, if there's particular things they need to be able to work or use or access, that it will be here that those sorts of functional issues will be dealt with. That's all.
Sure. I'll just show you this quickly. It's the same. It's exactly the same scenario. I'm not going to go through the whole thing, just so you know I didn't make it up. But yeah, it's the same thing. Look, it's just the only difference is that it's got the name, date of birth, that kind of stuff, hospital number there, and that's basically so that you're copying the same date of birth, notes, all that kind of stuff onto everything. And if someone asks you what your date of birth is and your hospital number, you know what it is. Do you know what I mean? If they're checking it, so it's the only reason to have it up there. So the patient has an identity. And just, you know, if you're doing the same scenario the following year, just make sure that you're updating the year, which you can actually tell there. I got the year wrong because we started putting this one together last year, even though it's been updated since then. I haven't updated years. So something just to be careful on. You can tell already it's not quite a year, is it? It's a year soon. It's a year next month. So it's just, you know, something to just be careful on. That you just keep an eye on the year. But what I actually wanted to show you was this. Can you see this page? Technical notes. Now, I find this really useful. I don't think you can see the whole page there, but I'll scroll down. So this is for the person that's kind of running the scenario, whether they're running the simulator or that kind of thing. But it gives you who you are, in case you're getting asked stuff. The history of the patient, in case you start asking you stuff. Drugs that you're on, all on one page, without getting into too much stuff. Everything's broken down into drugs. It's like a really quick thing to look at. You have all the other stuff that is kind of in the other document as well. It's there in just another form, more or less, you know. But here, these are my go-to pages when I'm running a scenario, to be honest with you. You know, non-instant dependent diabetic, you know, all this kind of stuff that, you know, you're going to need to know your initial setup for your thing. Now, you might set this up completely different and call it all different things. And then this one is more or less the same as, you know, the kind of transitions, you know, this is kind of how I do it. But it's the same thing. But they're the two pages that when I'm running a scenario, I'm looking at these continuously the whole way through, you know. That's how I started. And in the baseline, you know, when someone's talking to me, if I'm the patient or whatever, you know, I'm going to be setting my simulator like this, and I'm going to be communicating at the start with whoever using this information. And I'm going to be setting up the environment kind of off this a little bit as well. And then, you know, then you're going to be working through my transitions, you know, this way. Or using, you know, the other document. But, you know, it's the same kind of thing. But I think a form like, you know, maybe just putting something like that for yourselves, just something like this might be useful for you. I don't know. At the back, I don't know. It's up to yourselves, you know. If you're doing that kind of thing.
So I mean, on that, there is no difficulty with people adding supplemental documents with the template. I suppose to highlight that the adjudication will be based on, will be somewhat based on the template document, and the again, we'll send out an email with clarifications as to how that's going to happen. But you do need to sort of, as completely as possible, fill out the sections of the template that are pertinent to your scenario. But if there are supplementary documents such as this or other bits and pieces that you feel would be of value to be included, you are very welcome to, and they will all increase, of course, the value of your scenario. So there is no reason why you can't include something like this if it is something that
yeah, and I suppose it's more the practical side of running it rather than, you know, then maybe for the competition, I suppose, you know, I'm just thinking, you know, if you're running it, it might just, as a visual thing, I just find it my go-to page, you know, in all the documents is the one that I go to first, you know, for me, you know, but for the competition, you know, maybe it's not necessary, you know. I'm just showing it to people if they did want to do something like this, you know, it's there anyway. So I suppose, you know, that was a kind of based on one discipline, you know, nursing, and obviously the learning objectives would be different if it was multi-professional. But it wouldn't take a whole lot to change that, you know. I mean, you could have you know, the nurse and the doctor, or you know, a couple of nurses and a doctor, you know, could be the participants, and then you just think about how you change that. And you know, it could be the nurse then that's giving the adrenaline, the doctor could be looking after the airway, and it could be then the scenario could be slightly different, where it's anaphylaxis with a difficult airway, you know, where one nurse is, you know, helping the doctor with the airway, and they're talking through the plan of looking after the airway before they start, you know, managing the airway and working through the DAS guidelines and that kind of stuff, while the other nurses giving the adrenaline and that kind of thing, you know. So, you know, there'd be the kind of things that you could think about if that was an anaphylaxis in the ICU for you know, multi-professionals, you know. That's the way I'd be thinking anyway, you know, something along those lines. So there wouldn't be a whole lot you'd have to change, but you know, there would be certainly things you'd have to think about and talk to people and talk to other people and see what they would do, you know, and get people's perspective on how they'd manage it and what they do. But if anyone's any questions anyway, fire away anyway.
There was just one question that came up through the chat while you were doing it. Lee App wondered whether in a scenario you can kind of, whether you need to stick to real time or whether you can skip time and move further along a scenario. And is that something that you use regularly, Dave?
We don't generally do it that much. We generally, we keep everything to real time. I think it depends on what you're trying to achieve, and sometimes we've done it the odd time, but what we find is that it's kind of hard to, when you speed up time, then people don't really know if it's the real time anymore, or can other things be speeded up and slowed down. So we generally do things in real time. So I think it depends what it is, you know, because often we're doing things that it's managing the case right now in the, you know, in the time frame that you have, you know, and we're looking at that teamwork, and we're looking at that, you know, how people are operating and the teamwork, and using resources available to them right now. And if they want to send off bloods, you know, in the real world, they're never going to get those results back straight away anyway. So they still have to manage the case, and that's kind of how we operate. And if they were doing a blood gas, we'll send someone off with the blood gas, you know, one of the Confederates, and we'll actually give them the blood gas result, you know. So we'll do it that way, but we tend not to speed up time that much, really. The odd time we've done it for certain things, but it's not something we regularly do.
Lee is wondering if making a model for the scenario, do we need a prototype made or just provide instructions on how to make it? I mean, I guess, you know, a lot of that is, Lee, down to how proactive you're feeling about it. I mean, yeah, having an idea around how a sort of a DIY task trainer might work is good, but being able to show that your DIY task trainer has some value increases the sort of the likely impact of it when you're talking about a competition, you know. So it's up to yourself. I mean, certainly if you're going to be one of the people shortlisted to the final, it'll need to move from a set of instructions to a prototype, certainly. But whether or not you decide to do it before the 5th of May, that's just kind of up to yourself, I guess.
That's great. Yeah, thanks for that, Professor Cook.
Are there any other questions? think you've covered everything out, Dave. It's useful to see the way that you guys lay out your documents in advance of the thing. I think it was interesting, the level of detail that's in there. So so I think it would have been helpful. I suppose what might be quite helpful is, would you be able to email me that document that you produced, so that I can maybe distribute it to the various team contestants, just so that they can use it as a certain example that they can work against when they're filling out their own ones?
Or a way not to do it.
Well, yeah.
I know, yeah, absolutely. Yeah, there might be a couple of, I'll apologize now if there's a couple of spelling mistakes in it.
Yeah. I mean, I think it's really just, you know, I mean, the reality is that lots of people will probably struggle to completely follow this scenario or this layout, because their scenarios just won't necessarily fit with that, if you know what I mean. But at least it gives them an example of the sort of detail that you're talking about. So
yeah, like I see one spelling mistake I've corrected twice now, and I'm not sure why it's not corrected. Anatropes, and yeah, I corrected that already today. But anyway,
absolutely. Dave, thank you very much.
Sure.
Great. Okay, and I'll distribute that once we receive it. So thanks very much. That was a great session, very practical, and I think that has concluded all the questions.